Good evening, everyone who are assembled both in person and joining us on the Zoom online to celebrate Professor Krishnamurthy Srinivas's memorial lecture in 2026. So, without spending much of the time, I would like to invite Ms. Aparna Rajgopal to do the welcome and the invocation address.
Thank you so much, Vivek. Thank you, everyone. Good afternoon, everyone. Thank you for being here as we commemorate the 93rd birth anniversary of my father, Dr. Krishnamurthy Srinivas. My father passed away on November 1st, 2017. He was not only my father, but one of my closest friends and greatest cheerleaders. We miss him every day. In January 1965, after extensive training abroad in a field still new to this part of the world, he chose to return to India, to a country he loved deeply, and dedicate his life to community neurology at the Voluntary Health Services in Chennai. For 52 years, through rain, flood, and unrest, he walked through those hospital gates every morning with undiminished joy. For him, public service was not sacrifice, it was fulfillment. Though VHS served the poorest of the poor, his department became a beacon for neurology in India and beyond. He believed passionately in bedside medicine, clinical skills, public health, and the art of diagnosis. He brought global experts to Chennai long before communication was easy, building bridges through generosity and conviction. He would often say, with characteristic humility, God cures the patient, the doctor takes the fees. He taught for over 3 decades at Madras Medical College without remuneration, shaping generations of neurologists across the world. He valued EQ over IQ, character over credentials, and never raised his voice, yet commanded immense respect. As a father, he gave us freedom, books, music, swimming lessons, ice creams after poor grades, and above all, love without condition. He taught me that medicine can be dark and that the doctor must nourish the mind with literature, art, and music. He showed me quietly and consistently that compassion is the highest calling. He lived simply, gave generously, and treated every patient, rich or poor, with equal dignity. A doctor, he would say, must never ask about religion or race, only what is your illness. My mother, who is with us today, was a steadfast partner for 52 years, the quiet strength behind all that he achieved. Toward the end of his life, he would say he was ready to meet his maker if his maker was ready to meet him. I have no doubt that the maker must be very proud of this gentle, compassionate physician, an extraordinary son, husband, father, grandfather, teacher, and a lifelong student of life. It is in that spirit that I warmly welcome all of you, and especially Professor Kurt LaFrance, who will deliver today's commemorative lecture. Thank you all for being here.
அடுத்தது
संगच्छध्वं संवदत्वं संवो मनांसि जानतां देवा भागं यथा पूर्वे सञ्जानन उपासते समानी वयाकूत समान हृदयानिव समानमस्तु ओ मनो यथाथ सुसहासते संगच्छध्वं संवदत्वं शम्भो मनांसि जानता
Moving on, moving on to the next thing. So, as we all remember, Professor is always teaching with the anecdotes, the history, and the stories. So as to commemorate, there is a book on Professor's life, Tushitala. I will request Dr. Subulakshmi Natarajan to go like provide the reading and the excerpt from the book so that we can all cherish the old memories.
You can go. I consider it a rare honor to have been invited to participate in the event commemorating the 93rd birth anniversary of Professor Krishnamurthy Srinivas. I joined the professor as a junior doctor, and a professional association continued in the department over 35 years. As his biographer, I turned the page to 113, Chapter 9 of Tushitala, which is titled Clinician, Teacher, Researcher, Educator, Mentor, Leader, and which says it all. That's Tushitala. Krishnamurthy Srinivas' training in modern medicine neurology had been with eminent persons in the profession globally and in institutions of repute. He had consolidated this knowledge and the clinical skills to suit the Indian patient, both urban and rural, in a developing nation. The zeal with which he passed on his assimilated clinical diagnostic skills, primarily at the bedside and also in the classroom, through his library collection of select journals and books, and its culmination in bringing to the student's doorstep orations and workshops rendered by the best in the world, was history in the making. He had a deep interest in his junior colleagues and their career development. Srinivas was an educator in that he left a lasting impression on his students, sculpting them into future professionals of high standing and showing the way forward. One cannot but admit that he stands tall among the pioneers of modern neuroscience in India. From the launch of his professional career in India, Srinivas had his priorities worked out, giving precedence to individual patient care and treatment. The development of community neurology at Voluntary Health Services and Public Health Center had to go hand in hand with the individual patient management. In this effort, it was essential to create public awareness for promotive and preventive healthcare and to work out neurorehabilitation strategies to make the patient fit to the extent possible, to reclaim their lives in home and community. Teaching fell second in line, with research, mainly clinical research, occupying third position. If the author must do justice to Srinivas's biography, she cannot keep away from reproducing his frequent need to quote the founders and torchbearers of the medical discipline verbatim to prove a point, especially in the area of fine-tuning the clinical approach, as he was convinced that it could not have been said better. What is noteworthy is that he himself followed faithfully the central messages each quotation conveyed, without resorting to any shortcuts. When modern neurology seemed to override clinical methods and not complement it, the professor would utter a dismal cry, "Is clinical neurology dead?" But he would go on to reinforce in the article bearing the same title the glorious attributes of the clinical examination armamentarium in neurological practice towards diagnostic skills, which he was convinced was for all time. I end with Professor's favorite quotation by Robert Wartenberg, 1887 to 1956, who was known to have further refined the clinical examination in neurology. Wartenberg fled Nazi Germany to find a safer haven to continue his phenomenal work in California. Repeated history taking, quote, repeated history taking and physical examination is time consuming. It is the busy physician who is inclined to delegate the diagnosis to the laboratory in the vain hope of saving time. Too many irrelevant technical procedures only confuse the issue, cloud the essential point, and broaden the margin for error. Time invested in clinical examination might have paid greater dividend. Thank you.
Thank you. Thank you, Dr. Subalakshmi, for the reading of the excerpt and the citation. Moving on to read the citation and presentation, I now request Dr. V. Natarajan, a senior clinical neurologist from Chennai, to do the honors.
Overview or citation first? The whole citation. As you please, sir. Now, which is going to do first? Overview of the talk and the citation, or citation and then the overview of the talk? Just the citation and the overview. Good evening to all. Sorry. I am privileged and feel very happy to take part in the 93rd birth anniversary of my respected teacher, Professor Krishnamurthy Srinivas. I submit my humble pranams to Professor Srinivas and Madam Padma Srinivas. I am happy and I thank Professor ESK for having asked me to participate in this function. This citation, I'll read the citation. Before that, I would like to echo the sentiments expressed by Ms. Aparna Rajagopal, the daughter of Professor Krishnamurthy Srinivas, and Professor Subalakshmi Natarajan, with whom I was associated. And I was associated with Professor Krishnamurthy Srinivas for more than 25 years at the Institute of Neurology and then also at the Voluntary Health Services, where he used to call me and discuss the worldly affairs. Now I am going to read the citation. Dr. Krishnamurthy Srinivas, the 93rd birth anniversary commemorative lecture. This citation is respectfully conferred upon Professor Kurt LaFrance, Jr., in recognition of his outstanding and enduring contributions to the fields of neuropsychiatry, epilepsy, and functional neurological disorders. Dr. Krishnamurthy Srinivas, in whose memory this commemorative lecture is instituted, was a clinician and a teacher whose life exemplified the belief that a gentleman puts more into this world than he takes from it. This principle of generosity, integrity, and service finds a natural resonance in the work and spirit of Professor LaFrance also. An internationally respected clinician, scientist, educator, and thought leader, Professor LaFrance has profoundly shaped contemporary understanding of the complex borderlands between epilepsy and functional neurological disorders. Through rigorous scholarship, compassionate clinical care, and global leadership, he has advanced diagnosis, treatment, and the dignity for patients whose conditions challenge conventional neurological boundaries. As Professor of Psychiatry and Human Behavior and Professor of Neurology at Brown University, and as Chair of the Neuropsychiatry Commission of the International League Against Epilepsy, he has guided international consensus, influenced clinical practice worldwide, and mentored generations of clinicians and researchers. In delivering the Dr. Krishnamurthy Srinivas commemorative lecture entitled Epilepsy and Functional Neurological Disorders, Revisiting the Borderlands, Professor LaFrance honors a legacy of clinical excellence, intellectual humility, and humane medicine, values that Dr. Srinivas lived by and this lecture seeks to uphold. Presented with deep respect and gratitude on this commemorative academic occasion. The Buddhi Clinic, Chennai, 15th of February, 2026. Thank you.
It will be a virtual presentation, what you will see and receive, Professor, at your address.
Professor Madam Srinivas. Thanks. Just to give an overview of the topic, functional neurological disorders have come to be the key at present topic to be discussed worldwide. At one point of time, we considered what was functional neurologic disorders to be psychogenic or psychological. In other words, whatever we neurologists felt we could not put it into a slot, we could not put it into a diagnosis, we dubbed them as due to a psychiatric problem or psychological problem and passed it off to the psychiatrist. But now we have learned that it is no more so. What we had thought at that time, when we did not see any structural abnormality to account for the problem, we dubbed it as psychiatric or psychogenic. Now we know much more that these are in reality disorders affecting the nervous system. They are functional disorders in the sense that they affect the neural network rather than affect the function, rather than the structure, and yet that causes the symptoms, and hence we have to approach this problem as a neurological problem, as a functional problem. So it's no more a psychiatric problem or a psychogenic disorder. And there are several such disorders which we usually meet with in practice. And one of which is, of course, Professor Kurt LaFrance is going to address, namely epilepsy. Now, there are a lot of epilepsy-like presentations which confound us. We are not sure whether it is epilepsy. Now we know, see, the functional neurological disorders are no more an exclusion diagnosis. They are an inclusion diagnosis. It should be diagnosed based on the clinical features per se. We should say, no, this is a functional neurological disorder. Maybe it does not fit in with a regular condition. So several such conditions exist, not only epilepsy, much more headaches, movement disorders, pain, chronic pain syndromes, sleep disorders, all of which come under the purview of functional neurological disorders, and it is expanding more and more. And I am grateful to Professor ESK for having given me this opportunity to listen to the lecture by Professor Kurt LaFrance. On to you, sir. Thank you.
Thank you, Dr. Natarajan, for the introduction to the thing. There's a small housekeeping announcement that we will take all the questions at the end of the lecture. So you keep your questions ready with you or put it in a chat box, what you are seeing, and we will take it at the end of the lecture. Professor Kurt LaFrance, all yours.
Oh, thank you so much. What an amazing honor to be able to speak on this momentous occasion, to celebrate a birthday, to see family members and friends, and so grateful to all of you for this invitation, and to see Padma again, and Krish and Aparna, and having just been there in December. I've been in that room where you are sitting, and I'm so appreciative to be able to be part of this. I'll share my screen. Sharing is not turned on. Send request. Request has been sent. Good. And my slides here. Share. Wonderful. And let's do this. I'll put it in presentation mode. Okay, is that projecting okay now?
Yeah, perfectly.
Wonderful. Good evening to you. Good morning here from wonderful New England, cold, wintry New England. And here you see the beauty all around, a little bit different than there in Chennai. This is right outside the door in the neighborhood. And would love to, as you have hosted me there, would love to host you here. These are my disclosures that I'll be talking about some of the research that was mentioned. I wanted to, a lot of times I try and think of a word to capture the occasion. And in this case, in being able to, celebrate the life of and the birthday of Professor Krishnamurthy Srinivas, I thought parlaying was the right word. And to give that some context, as you know, parlaying is transforming something into something greater or more valuable. And I think that's what I've been hearing, is this transforming that has occurred over the years in the life and the career. And it's transformed into some of the topics we'll talk about today. We'll talk about professors and paroxysms and patients and psychotherapy and psyche. So these are our parlaying topics in the context of his influence parlay. So starting off with professors. This is the reason that we are gathered and are talking today. And so thank you so much, Krish, for the invitation to speak to the Buddhi Clinic Krishnamurthy Srinivas birth anniversary. I received the book that was sent, and thank you so much for that. To be able to read through the life and the accomplishments was absolutely wonderful. And Dr. Natarajan, thank you for the reading that you did. I always learn something new, and in the chapter that you read, toward the end of that, is a new pearl for me that Joseph Bell influenced Dr. Srinivas, and Joseph Bell was the physician who influenced Arthur Conan Doyle, who was the creator of Sherlock Holmes, and I'm a big fan of that. So to see that tied together, to learn in Tushitala, the teller of stories, was wonderful, and I'm grateful for that. More professors. The work that we do here is similar to what I was reading in the book, that the influence, not just one's own work, but the downstream effect and the collaborators and the friends around the world and around the country, and having that common tie to Professor Srinivas was also wonderful. The impact that he's made in India and globally, and seeing that effect there in the clinic and elsewhere, and then also here, being able to have friends and collaborators around the world, professors here and abroad. More professors. There's a younger Dr. ESK, and there's a younger Dr. LaFrance there at the Srinivasan Knowledge Conclave in 2011. I've been the gracious recipient of the hospitality of Krish, and am so grateful. And it was there where I was able to meet the family, and I was able to spend some time. It was there that I heard the story about a box that the professor always carried with him. And it was this past recent visit where I was reminded of the meaning of the box. And in essence, it's having the things you need to be prepared. And so it was wonderful to hear those stories there at the Madras Club. And so the influence there, again, passing the baton with Professor ESK, here you see some of the leadership that he has contributed to in the International League Against Epilepsy, looking at the neuropsychiatric conditions associated with epilepsy. And so we're really bringing things together. This is life and family and passing the baton and looking at neurology and psychiatry. And so that you see this tradition and another example of parlaying, transforming something into something more valuable. So we've talked about professors. Let's talk about paroxysms. Paroxysms, as you know, are things that are there and then they're gone. Interestingly, and with the introductory remarks, instead of thinking, is it neurology or is it psychiatry? The way that having been trained in both and practicing both, there's the phrase that you're aware of, to a hammer, everything else is a nail. So as a neurologist and a psychiatrist, everything is neuropsychiatric. It's not either or, it's both and. So when we think about paroxysms, yes, many times we think about, as neurologists, we think about epilepsy or seizures, we think about migraines. I would encourage you to broaden that definition of paroxysms into neuropsychiatry if you don't already, and that being basically a panic attack is a paroxysm, not unlike an epileptic seizure. You can broaden it even more. You can think of unipolar depression as being a paroxysm. They are euthymic, and then they are dysthymic, and then they come back to euthymia. So yes, it's not the immediate onset and offset like you might see in the more quote unquote paroxysmal disorders of a migraine or a seizure, but all of these neuropsychiatric conditions are just variations of a theme of paroxysms. And that's how you can unify your thinking about neuropsychiatric conditions. So an example of a paroxysm, some people have both epileptic and non-epileptic seizures. About 10% of patients actually have mixed epilepsy and non-epileptic seizures. So to look at them, one must be aware in that paroxysm of not tell me about your seizure, but tell me about your seizures. The importance of history taking that was described by Dr. Wartenberg and in the book that we heard from here, same thing. There will be some ictal or seizure semiologies or physical characteristics of. And so you want to hear not just about the seizure, but about the seizures. And here you can help, this can help to distinguish in the paroxysms that the patient experiences. I'll start with a case that, that's where we start as physicians and clinicians. So many of you might have heard of, most of you have heard of PTSD, post-traumatic stress disorder. Some of you have heard of moral injury. And this is a case who I was confronted with. I work with civilians and veterans. And many times chief complaints in the clinic are, I have a seizure, or I have a headache, or I had a stroke and I can't use my arm, or I have depression and I thought about harming myself, or I have flashbacks. The chief complaint for some of these patients that I had to learn about, one of them, a veteran who had served overseas, his statement was, Doctor, and I asked, what brings you here to see me? And I asked that question, and he responded as his chief complaint, Doctor, I'm a monster. I said, tell me more about that. And so being a monster in his case was related to every time now that he's back from service and he is at his house and his little girl runs up the driveway and he greets her, he actually sees the unfortunate little girl who stepped in front of his target when he was on mission. And so therefore he in his mind is a monster. That is part of the struggles that some of our patients, where if we understand and we enter into their suffering, in this case, moral injury, for those of you who might not be familiar, is the act, either carrying out an act or witnessing an act, being witness to an act that goes against your moral compass. In lay language, some people call them a soul wound. And that's what this person experienced. I told this man at the end of the exam, I don't have a pill that's going to make this go away. There is no anti-monster medicine that we have. I'll tell you more about where we were able to help this man. So as you know, for framing this, what used to be called hysteria, what has been called psychogenic, what has been called conversion, what has been called somatic symptom disorders, these are unconscious processes. These are not people intentionally faking with functional neurological disorder. And so trying to understand that one way that we might be able to help these patients is to make the unconscious conscious. Another element of these is that in paroxysms, they are not only seizures. As you know, you can have, just as any neurogenic presentation can occur, a psychogenic presentation can occur. So somebody who has a gait disorder from a spinal injury you can have a gait disorder from a functional neurological disorder, or you can have a functional motor disorder, or you can have functional cognitive disorder. And so all of these variations are these presentations that you'll see. In light of that, having a multidisciplinary team, as you do there in Chennai, is so, so important. And along those lines, what used to be relegated to psychiatry and dismissed by neurology, as was described, now is seen kind of as a global village, if you will, where we've got PT, OT, speech, we've got neuropsychiatrists, neuropsychologists, we've got mental health clinicians, we've got people in basic science who are looking at this amazing, fascinating, and challenging neuropsychiatric condition. We've made some great advances, and in doing so, being able to look at the progress that has occurred, interestingly, in the past decade, whereas it was flat for a long time, the publications have shot up exponentially, and realizing that there are different interventions that can be used, physiotherapy, conventional cognitive behavioral therapy, and others that we'll talk about. There are also what are called self-help interventions for the people who do not have complex trauma histories, for the people who have recent onset, for the people who do not have significant comorbidities. That's where I've seen the effect of self-help. That's not the majority of our patients, however. The majority of our patients have complex social, developmental histories and histories of trauma or abuse. And they've been carrying these diagnoses for years. So that's where I think as clinicians, we come in to help walk the patient forward. There have been some great studies that have come out. Laura Goldstein in the UK has done a multi-site study comparing seizure-focused CBT, cognitive behavioral therapy, versus standard medical care. And whereas the 6-month outcomes showed a separation, the 12-month outcomes for the primary outcome did not show a difference. However, the benefit to the patients using conventional CBT were found in the secondary outcomes with improved quality of life and functioning. So amazing job that Laura has done. Our systems approach basically incorporates not just the medical team as clinicians, but it also incorporates the importance of the home. It incorporates the importance of the community. So I tell people, yes, the medical team is part of your care, and also family, friends, and faith are very, very big components of your care. When I started this journey after finishing the combined residency in neurology and psychiatry at Brown, I went into my clinician, educator, research administrator role. And one of those was doing a study looking at medication for non-epileptic seizures. At that time, my distance mentors, including Orrin Davinsky, we reviewed the literature and found there was just consensus statements. We didn't have a strong evidence base. So as a young man, tried to organize a group, a workshop, and brought international leaders together to develop the research agenda to move the field forward. Continuing along with the parlaying topics, let's talk about patients. I've given you one example of a case. I'll tell you more about the patients who have these symptoms. Comorbidities are the rule, not the exception. What I mean by that is when you see somebody who has non-epileptic seizures or functional dissociative seizures or psychogenic non-epileptic seizures, however you want to refer to it, you're going to find that half of them have a history of depression. Half of them have post-traumatic stress disorder. Those who have military service are going to have higher numbers than that. Many of them are going to have a characterologic traits or a personality disorder. Not always, as we suspect, borderline personality disorder. Sometimes it's what we call cluster C or obsessive compulsive personality disorder, not OCD, like you have to wash your hands all the time, but the personality disorders. Those are the things that actually influence the outcomes. So they have to be addressed. Another common comorbidity that you'll find is that traumatic brain injury occurs. About half of patients in our sample reported TBI, and 3/4 of those were mild TBI. So you not only have, if it is mild TBI, as you know, they retain awareness. They might be dazed and confused, but it's not the same coma effect of moderate to severe with loss of consciousness TBI. So in this case, these people have had a double hit. They've had the physical hit from the head injury, but also the emotional trauma from seeing, from being awake during the assault or during the car crash or during the event in theater. And so we have to be aware of these comorbidities in our patients. I also wanted to bring you, there's some older literature and some newer literature. For those of you who are interested, Brain Injury Professional, this was actually just published yesterday. So this is truly hot off the press. It's a whole special issue on functional neurological disorder after head injury. And so one of my mentees, a wonderful neuropsychologist, Ryan Van Patten, and I published on functional seizures and traumatic brain injury, a biopsychosocial assessment and treatment. I broadened that actually to biopsychosocial spiritual that we'll talk about. More on parlaying topics. Many times we think of, well, what can we do in medicine? Well, we can give pills or we could do surgery or we can do neuromodulation. And that is where, unfortunately, some people stop. I'm going to encourage you that we have more to offer. And psychotherapy is what we're talking about. So again, we're talking about epilepsy and non-epileptic seizure, epilepsy and functional dissociative seizures and bridging the divide. One of the places that happened for me early in my career was seeing a psychotherapy for epilepsy that was produced by Ryder and Andrews out in California. I saw the impact of that in epilepsy, and I asked for permission. Can we modify that for non-epileptic seizures? Because they were showing a reduction in epileptic seizures with this neurobehavioral treatment. They used that for aura interruption, to reduce epileptic seizures. They used it for trigger self-control to reduce epileptic seizures. And so with that, I, with their permission, was able to integrate non-epileptic seizures into that workbook. And we did a multi-site trial where we actually found for the 2 therapy-containing arms, neurobehavioral therapy or neurobehavioral plus medications, a reduction in non-epileptic seizures. The medication, the serotonin medication, showed a trend in reduction as it had in my earlier NINDS, NIH K23 study. And then treatment as usual, standard medical care showed no significant difference, no significant reduction in seizures. This was important because the epilepsy centers around the country and around the world, we modeled standard medical care after that, and it showed no reduction in seizures. Therefore, we had to do something. We had to raise the bar in our epilepsy centers. And it wasn't just about seizures, it was about the comorbidities that I mentioned earlier. So in this, we saw a reduction in the trauma symptoms in the 2 therapy-containing arms, no significant change in the treatment as usual. This is our theoretical approach. We borrowed it from the pain literature, where it says non-epileptic seizures in the middle. That actually, for Vlaien's work, it said pain, chronic pain. So we asked for permission. We're able to modify this. A remote or an acute injury or trauma occurs, sets up a symptom, the paroxysms that we talked about, whether it's a non-epileptic seizure or a functional movement disorder or chronic pain or functional cognitive disorder, then they catastrophize. Their whole world is falling apart. They fear the unknown. When's the next seizure going to happen? They also are avoidant of external stimuli. They're hypervigilant to internal somatic cues. And then they move into this vicious cycle of disuse, disability, and depression. From there, their life falls apart, unfortunately. With our treatment with neurobehavioral therapy, we equip them with the skills and tools to be able to address that vicious cycle, to make the links, and then to break those links. And in doing so, they confront the fear, and then they move into recovery. And it can be life-changing for patients. So there are, because I did neurology and psychiatry in that training, I had exposure with supervision to various different types of psychotherapies. And I realized there's not one best. So some people swear by this one or that one. I will say, you know what? There's not one that is the panacea. And so what we did is we took the best of the different therapeutic modalities, and we targeted the known pathologies in each of the individual chapters, equipping patients with individual skills and tools. So yes, there is cognitive behavioral therapy elements. Yes, there is some mindfulness involved, but also interpersonal therapy to help people develop communication skills. There's also, as they're equipped, we assist with psychodynamic issues to help the unconscious to become conscious, and also realizing that self-efficacy and self-management, helping the patient to take control of their symptoms, is so important. So one of the questions that gets asked to me is, what's the difference between cognitive behavioral therapy and neurobehavioral therapy, which we do? I tell people it's a couple of things. One is that with CBT, and this is from people I've trained who have had both trainings, as have I, the comment is basically there are things like CBT for insomnia, CBT for headache. And what I've heard from the trainees is that the CBT treats the symptom. Neurobehavioral therapy treats the patient. And so in doing so, it's a whole person approach. It's also with neurobehavioral therapy, we not only treat the here and now like cognitive behavioral therapy does, we also address the then and there, and we make those links, the here and now with the then and there. We've been able to deliver this via telehealth. Because not everybody can come here, we try and reach out. And so with that, pre-pandemic, I'd already seen in my telehealth clinic 100 patients using telehealth, and we showed similar reductions in symptoms, both telehealth and in clinic. And for those who have rural patients or people who might not be able to get to your place, that's where the benefit of telehealth can come in. So with all of that, we wanted to see not only the clinical impact, but also the biomarker mechanistic impact. And we did that with a clinical trial that was funded some years ago now. And the three groups were TBI without seizures, TBI plus epilepsy, and TBI plus non-epileptic seizures. And those three groups, we enrolled them. The two seizure groups got the neurobehavioral therapy. The TBI group received standard medical care and didn't get the seizure therapy because they didn't have seizures. And what we did is we tracked them over time with after the neurobehavioral therapy. We found, as had been shown before, reduction in epileptic seizures and a reduction in non-epileptic seizures. So we were able to confirm that. We also showed outcomes, the comorbidities that I mentioned, an improvement in functioning, a reduction in somatic symptoms in the two therapy-containing groups, but not in the standard medical care treated TBI group over time. And then we also showed durability, which is reduction in depression scores. They maintained that reduction, and then reduction in seizures over time. Again, the depression scores, no significant change in the treatment as usual group. So those are the clinical outcomes that we reinforced. All that to say, recently, again, I'm bringing you the latest, greatest research here, that in January of 26, the American Academy of Neurology published the AAN Guidelines Subcommittee, published the practice guidelines for management of functional seizures. This was a 5-year endeavor with experts from around the world as we reviewed all of the literature that was out there. Specifically, what we found is that psychological interventions in general can be helpful at possibly achieving seizure freedom, reducing functional seizure frequency, and reducing the comorbidities and improving quality of life. Included in those types of psychological interventions that we reviewed and the literature was available for were neurobehavioral therapy, paradoxical therapy, psychoeducation, REACT, and CBT. So all of that work over decades has actually culminated now in equipping neurologists and psychiatrists and other clinicians that there's a practice guideline that you can utilize these interventions, these psychotherapies to help. One of the things that I wanted to do in my work was, again, as a neurologist and psychiatrist, and as was mentioned in the introduction, we were looking not only at the psychiatry, the psychology, but also at the brain effects. And so Eric Kandel had a big influence on me when he talked about the impact of psychiatry not only being clinically relevant, but also potentially altering the anatomical pattern of interconnections between nerve cells of the brain and how we could evaluate that as an outcome of psychotherapy. So, as you know, Freud was a neurologist who invented psychoanalysis, which became psychodynamic psychotherapy. Beck was a psychiatrist who created cognitive behavioral therapy. These were two different fields, related but separate in their thinking. My approach was, as a neurologist and psychiatrist, why not bring those together and incorporate the others? And we could actually have a synergistic effect. So doing so and looking at this from the biomarkers perspective, some work that was done by Vanderkruis showed a hyperconnectivity between the insula and the precentral sulcus in patients with non-epileptic seizures as compared to those who without healthy patients, bypassing executive control in the inferior frontal gyrus and parietal cortex. I wanted to see if there was a signal for that. And in fact, with that DoD grant, we did. And what I mean by that is that after patients, we did structure and functional neuroimaging before neurobehavioral therapy and after neurobehavioral therapy. And we found that in the patients with TBI and functional seizures, there was increased functional connectivity between the right anterior insula and left supplementary motor area. Not only did we find the functional connectivity, but we also found structural connectivity changes. So the idea that, oh, well, this is a software problem, not a hardware problem. I know that gets relayed to patients a lot. It looks like that there's a hardware problem too. Now, I'm not saying that there's a focal lesion like we see in our patients with temporal lobe epilepsy, or for those who have, who have stroke. What I'm saying is that in those nodes and the networks, those are affected. So here we see that gray matter volume changes in the left inferior temporal lobe in the patients with TBI plus non-epileptic seizures was found in our study post neurobehavioral therapy. So what we've concluded from that comparison of TBI versus TBI plus epilepsy versus TBI plus functional dissociative seizures is that we can reduce seizures, both epileptic and non-epileptic, after neurobehavioral therapy. We can improve comorbidities. We've demonstrated durability, and we've also demonstrated neuroplastic changes after neurobehavioral therapy. We've changed the brain with psychotherapy. So now you actually have an evidence-based, manualized, multimodality psychotherapy for patients with seizures, both epileptic and non-epileptic. That's been published in our books in the Oxford University Press series, Treatments That Work, the Taking Control of Your Seizures workbook. And also for those who aren't able to do training with me or the people that I've trained, there's the Therapist Guide for Treating Non-Epileptic Seizures to describe the nuances and the challenges in this population. I mentioned earlier about professors and patients and psychotherapy. These are people around the country, in the US and in North America. These are not only mental health clinicians. These are also epileptologists who are incorporating these treatments into their neurology clinics. These are neuropsychologists who are not only doing testing, but they're also doing intervention. Neuropsychiatrists, neuropsychologists, social workers, people around in the civilian clinics, and also in the Veterans Administration. Same idea, being able to broaden the impact so that people can be equipped to deliver this intervention. And now, whereas before there were very few centers, there are a number of centers around the US who have people who are trained to be able to deliver the care. The VA Mind Brain program is something that I was asked to lead up. It's a national organization basically to bridge mental health and neurological care for complex neuropsychiatric conditions. And we do that through training and education and through clinical care and research, helping to start clinics around the country as people need. And we've got people trained around the country to be able to do that, to help with that. For those who aren't in the VA, logging in, and I think even outside of the US, train.org, typing in neurobehavioral therapy or neuro-behavioral therapy can get you to the modules that are online that are available for this. And we've shown that these aren't only for seizures, but they're also for other presentations that I mentioned earlier in the talk. So people who have motor functional neurological disorder or other symptoms have shown an improvement in symptoms in their global assessment of functioning and also their clinical global impressions. I mentioned about psychotherapies. So looking at the psychotherapy, and also I mentioned about what we think of as clinicians for treatment. So you think many times we're taught in epilepsy, we have anti-seizure medications, we have epilepsy surgery, we have neuromodulation, and we also have diet. And typically, from an allopathic medicine perspective, those are the four that we think of. Again, I'm encouraging you in neurology and psychiatry to think also of psychotherapy for epilepsy. This is a task force that was, again, multinational task force where we looked at the literature in psychotherapies in epilepsy. Those might have included cognitive behavioral therapy or motivational interviewing or mindfulness. And what we found was that the overall effect was that it was significantly higher for quality of life in patients with epilepsy who received psychotherapies. So here, one more arm in your armamentarium to help your patients with epilepsy using psychotherapy. So with that, there are a number of resources available from the Managing Epilepsy Well Network, and that includes a cognitive training with hopscotch. It includes addressing depression. It includes addressing, and this is in young and old. So you've got a number of resources available that can be used in our patients with seizures. Because I mentioned that we've not only impacted seizures, we're also aiding patients with functional neurological disorder who have motor FND, what has been called psychogenic movement disorder or functional movement disorder. So we've modified the Taking Control of Your Seizures workbook to Taking Control of Your Functional Movement Disorder. We're about 3/4 of the way through our clinical trial at Rhode Island Hospital, one of the hospitals where I work. And hopefully we'll have the preliminary pilot randomized control trial with these outcomes coming out soon. Similarly, your patients who have mild traumatic brain injury or who had a closed head injury and they have prolonged post-concussive symptoms, those are people who might qualify as functional cognitive disorder. The people who after a year, they continue to have their symptoms, even though it was a quote unquote tiny bump on the head, a small bump in the vehicle, those raise the question, is there something else going on? Might it be also PTSD, that double hit that I talked about? So with functional cognitive disorders, these are people who have memory issues, freezing, word finding, brain fog, but it's not like the dementia cases with our Alzheimer's or our neurodegenerative processes. So for that group, we've created Taking Control of Your Functional Cognitive Symptom workbook. And again, trying to target really making the symptom relevant to the patient and addressing those with the interventions. So as we get close to wrapping up, how do you explain this to your patients and to your clinicians? Well, what is a functional neurological disorder? I tell people it's a neurological manifestation of an underlying psychological conflict or stressor being a life event. And it's also a behavioral expression of neural network dysfunction. It's brain and mind. It's both and. It's not either or. It's neurology and psychiatry. This resonates with a lot of people after you've taken the history and you feed it back to them in the formulation. We've talked about a number of parlaying topics here. We'll close out with psyche. As you know, psyche comes from the Greek. We'll talk a little bit more about that. One of the things that I learned as a physician early on in my training was it's important to take care of the whole patient. A man who mentored me told me, Kurt, patients will bring you their felt needs, and if you give them the space, they will disclose their real needs. And in that place, it's where clinical concerns are presented. Again, in a space where patients can open up, then they're going to really address their existential or spiritual concerns. And those are those domains of overlap, such as identity and hope and meaning and purpose and morality and mortality. All of these can come up if you give them a place to do that. I opened up with that case about moral injury because as a clinician researcher, if I don't know about something, I'll do a study on it to try and learn. And so in this case, I did a study on moral injury in veterans with non-epileptic seizures. And it is different than PTSD. It's not the same thing. And what we found is in moral injury, they had higher reported guilt and depression symptoms, and they were younger also, different from patients who did not have moral injury and non-epileptic seizures. So when I was talking to that patient, that veteran who I mentioned at the beginning, who said, I am a monster as his chief complaint, I said, we're going to have to address something over and above what we do in medicine. We can address biology with medications. We can address with psychotherapy some of the PTSD. We can address the social implications as it's affected your family and your work. We also need to address the spiritual element. And in that, when I mentioned about psyche, as you know, has it, in the way it's been translated, psychiatry, psychiatria, is translated as mind physician. If you break it down to the original etymology in Greek, psyche is also soul. Iatros is also healer. We can go from being a mind physician to being a soul healer if we want to take on that mantle. And in doing so, we've done that with neurobehavioral therapy, which is an integrative, whole person, holistic approach, biopsychosocial spiritual, addressing the whole person in the continuity of their humanity. It's patient-led and therapist-guided, and it also addresses the here and now along with the then and there. And the paradoxical surrendering of control to gain control is a component of that. In the case of this patient, the prescription was forgiveness. It wasn't a pill. He ended up having to forgive himself, and then he could forgive others when he was in that position. That's what actually brought him hope and healing going forward. So with that, I'll close out basically saying in epilepsy and movement disorder, we target channels and synapses and circuits. We also do that in functional neurological disorder, along with cognitions, emotions, behaviors, and language. And we help people with their cognitive dyspraxia of the self, and ultimately they are able to know themselves. So treatment involves getting the diagnosis, making the diagnosis with video EEG, creating a problem list, which informs a prescription, tapering the medications that aren't needed, adding the ones that are, and then using the psychotherapies that help. With this, hopefully, with this work, you can diagnose and you can treat functional neurological disorders. You can restore quality of life. You can work with your colleagues in rehab. And then in your clinic where you address this, it's very rewarding for clinicians, and it can be life transforming for the patients who come in with the inability to walk and go out skipping, literally, as I've seen patients. If you're interested in this, please feel free to join us at the International F&D Society Conference in Baltimore, Maryland in June of 2026. And we would love to have you there to be able to discuss this. And with that, I will close. If y'all are talking in the clinic conference room, I'm not hearing anything. It's not hearing anything, Krish. Nope. Dr. Natarajan, are you able to hear anything from the clinic? So I'm not sure. I'm not hearing you either. I'm not sure what that is. You're muted, Dr. Natarajan. Now I hear you.
Yeah, wonderful. How I enjoyed your talk. Great.
If you're hearing, are you hearing what they're saying in the clinic?
Not at all. No.
Okay. Just wanted to confirm.
Aparna, are you hearing?
I can't hear anything either. It was wonderful.
Okay. I hear the two of
Professor
you.
France. It was wonderful.
Good to see you. While we're working on the audio in the clinic, I do want to say thank you so much for the book that you did. It's just amazing to see the biography and the work that went into that, and the love, not only that's manifested here through the individual, but also through the family. So it was really wonderful to see that.
Yes.
They are just getting back on audio. There's a message.
Great. While we're waiting, I see a question in the chat. What about absent or absence seizures? Can it be treated as well? And does the client have to take medications lifelong? Good question. So regarding absence seizures, that's just one of the manifestations. For the epileptic trials, for the epilepsy trials, those were partial focal seizures. And they may have had a subset of absence seizures that were done with the Andrews-Rider approach. Not sure. For the non-epileptic seizures, ictal manifestations, the semiologies, any manifestation, ictal semiology, they might present with a generalized tonic-clonic or an absence or a focal seizure, and each of those semiologies have responded to neurobehavioral therapy. Does the client have to take medications lifelong? It depends on which medication you're talking about. For epilepsy, more likely than not, they're going to remain on an anti-seizure medication. For non-epileptic seizures, anti-seizure medications don't treat non-epileptic seizures. So in light of that, if there's not another indication for the anti-seizure medication, such as a mood stabilizer for bipolar disorder, or headache prophylaxis for migraine, or for chronic pain conditions where you would use an anti-seizure medication or a mood stabilizer, you'll maintain them on that. If it's non-epileptic seizures without epilepsy or one of those indications, you can slowly taper off the anti-seizure medication.
So there is a caution in-house that is there any first aid for epilepsy?
Did you say first aid?
Yeah. First aid.
If I can expand on that, how would a person,
Please.
we talk about how to deal with a patient who is having a seizure. What about non-epileptic seizures? How do people deal with someone who's been diagnosed to have non-epileptic seizures when they are having an event?
Great question. So there's a term in allopathic medicine, primum non nocere, first do no harm. So what I have to teach in the emergency room, if somebody is having a known non-epileptic seizure, if the ictal semiology has been captured on video EEG and you know that it's not epilepsy, and somebody is having their typical event, in medicine, we're taught, you've got to get in there. You've got to stop the status epilepticus. And so for epilepsy, we've got this algorithm that we use. For non-epileptic seizures, there's not a medication that's going to stop it. So in that case, I have to teach, don't just do something, stand there. And in that case, instead of rushing in and paralyzing and intubating the patient for presumed status epilepticus, it's actually be present, make sure that the patient is safe, guardrails up with handrails up with pads on the side. Don't let them just thrash about. Make sure that they're safe. If they're potentially hitting their head, clear the objects. If they're on the floor, put a pillow under their head. All of those things to create a safe environment. And then don't call a code. Don't draw more and more attention. In fact, just being a presence there, letting the seizure subside, and then normalizing it with, well, what just happened after that, to help the patient reflect. That's the intervention. Instead of increasing acuity, really trying to settle things out.
An excellent coverage of functional neurologic disorder. Thank you very much, Dr. Kurt.
Thank you.
One question is, PTSD, what is the best drug other than phenytoin?
For post-traumatic stress disorder?
Post-traumatic seizure disorder.
Stress disorder.
Which one? Are you talking about post-traumatic seizures or post-traumatic stress disorder, PTSD?
No, post-traumatic seizure disorder.
Post-traumatic seizures, yes. So if you're talking about post-traumatic epilepsy, then in that case, there are the interventions that you would use to treat typical epileptic seizures, you could use to treat post-traumatic epilepsy. Same idea. For post-traumatic non-epileptic seizures, we've found that for TBI, for non-epileptic seizures after head injury, we found that neurobehavioral therapy has helped those patients.
What is the drug other than
you can use, so you can use phenytoin, like you mentioned. You can use valproate. You can use the newer medications. There are a number of medications that can be used in post-traumatic epilepsy.
Levetiracetam?
Levetiracetam, yes, absolutely.
Thank you.
Yes.
So, Prof, there is one question from my side that I read one of your paper where it's shown that the neurobehavioral therapy do bring the neuroplastic changes in functional seizure. So, are there any other non-pharmacological interventions, just as we use for other maybe like PTSD or anxiety disorder, how well we can promote that neuroplasticity using especially the non-pharmacological options what we got?
Great question. I don't know the answer to that because I haven't seen the studies that they've done a pre and post structural and functional neuroimaging before that non-pharmacologic intervention like what you're describing. That would be a great study. So when you are ready to run that, let me know and we'll work on that. Love to see that. I will say this. Yes, I will say this. Recent research has shown, and y'all are already aware of this, I'm sure, that exercise has shown some significant reductions in depression to the similar effect or even better than pharmacologic therapy. So I tell my patients, it's the things we try and encourage in our patients, healthy living. So getting a good and steady sleep pattern, sleep hygiene, as we refer to it, daily exercise, do as much as you can, but not more than that for brain and body health. And then also, trying to avoid toxins, if you will. So people who have substance issues, if they're able to get treatment for their alcohol and drug use, all of those things. And then incorporating faith, as I mentioned. I give a lecture at Brown on spirituality and medicine. And in that lecture, I go through the significant literature that shows reductions in depression, reduction in anxiety, improvement in substance use, an improvement in cardiac health in people who have higher practicing patterns in their faith.
Thank you, Professor. So I think if there is no other questions, I will request Dr. Rama to give the vote of thanks and close the session.
Distinguished guest, Professor Dr. Kurt LaFrance, colleagues and friends, as we conclude this memorable evening, I'm filled with deep gratitude. We gather today to honor Professor Krishnamurthy Srinivas, whose pioneering work in community neurology and unwavering commitment to accessible healthcare continues to inspire us. This is not merely a memorial, it is a recommitment to the values he embodied. My deepest gratitude to Professor Dr. Kurt LaFrance for joining us from across the globe to deliver an exceptional lecture on epilepsy and functional neurological disorders, revisiting the borderlands. Your willingness to share your expertise honors Professor Srinivas's vision of bringing international knowledge to Indian shores for our medical community's benefit. To all who participated in our afternoon workshop on biopsychosocial spiritual approach in neuropsychiatry, thank you for engaging so thoughtfully with this holistic framework that Professor Srinivas would have deeply valued. I want to especially acknowledge Professor Krishnamurthy Srinivas's family for continuing his extraordinary legacy with the same values and commitment to service that defined his life's work. To Dr. E.S. Krishnamurthy, thank you for embodying these principles at Buddhi Clinic, where seva, selfless service, remains at the forefront of everything we do. To all those who joined us online via Zoom and shared this evening with us, thank you for being part of this tribute. The best way to honor Professor Srinivas's memory is to continue his work, to serve with excellence, to practice with compassion, and to ensure neurological care reaches everyone who needs it. Thank you all for keeping his legacy alive. Thank you and good night.
Thank you.
Thank you, Prof.
Great to see you.
Thank you, Kurt. Thank you for your time and energy and a wonderful contribution. Thank you. Thank you, Aparna, Dr. Subbalakshmi. Thank you.